Hello, this is Rachel Babin from Oncology News Australia. Welcome to the C Word, a special COVID-19 episode of the Oncology Journal Club. As regular listeners will know, Eva, Craig and Hans have resisted an episode on COVID-19. Like the rest of Australia, they felt and hoped that we had escaped the worst of this pandemic. However, in the last couple of weeks, the situation has become much more difficult in Victoria and dire in some parts, particularly in nursing homes. This special episode will bring you up to date with the latest literature on COVID-19 and cancer. Our format is a little different this week as Eva Segelov gets us started with a very special interview with Professor Raina MacIntyre, one of the world's leading authorities on pandemics, who shares some very important insights on COVID-19. This will be of broad interest, not just to those working in healthcare. So I encourage you to share this episode with family and friends so we can spread these important messages as widely as possible. In the second half, Hans Prenen gives us the European perspective with papers from Belgium, Italy and Spain. Craig Underhill shares some insights from the UK, and Eva also gives us some COVID quick bites. Please forgive Eva's sound quality in places. She is recording remotely from lockdown in Victoria in less than ideal circumstances. As ever, the links to all of the papers discussed today are available in the notes. For the latest oncology news and podcast updates, you can subscribe to the Oncology newsletter for free on oncologynews.com.au. This is Rachel Babin, and this is the Oncology Podcast.
We have a really special opportunity to interview my good friend, Professor Raina MacIntyre, who is the head of the Biosecurity Research Program at the Kirby Institute, UNSW. She's a Professor of Global Biosecurity and an NHMRC Principal Research Fellow. She's an FRACP physician in infectious disease, an epidemiologist, and her particular expertise is in pandemics. She's been telling me for years one is coming. I've always thought that she was a little dramatic, and look where we find ourselves now. Raina is a very passionate advocate for care of healthcare workers, cancer and other vulnerable patients in particular during the pandemic. So today we're going to focus a little bit on COVID and cancer patients, but also very importantly, the issue of keeping our healthcare workers safe. We're very lucky to grab some of your time, Raina. Thank you very much.
It's a pleasure, Eva. Happy to be here.
So, Raina, can I start with just a little update, a global update? Where are we with COVID? Is this pandemic playing out as predicted? What's going to happen in the future?
So it's getting worse globally. Most countries are pretty badly affected. And, the thing that really took us by surprise is that high-income countries with good technology and good resources are doing very badly, like the United States. So it's not just about having resources. It's also about systems and processes and governance and accountability and a lot of other factors that have come into play. And time is of the essence when it's an epidemic-prone disease and a pandemic, because these diseases grow exponentially. They don't wait. You can't afford to sit around for a few months thinking about what you're going to do. The disease will grow exponentially. So every 2 weeks, the number of cases will double or triple. And you can get a lot of silent epidemic growth because the majority of people have mild or asymptomatic infections. So you may not even realize there's epidemic growth going on until it's so big that 20% of severe cases starts impacting the health system.
Do you think it's human nature that's held us back?
No, I don't, because human nature is universal, but there's been some countries that have managed the situation much more successfully than others. New Zealand, Australia for a period of time, and countries like Taiwan and South Korea as well.
I was more referring to this sort of feeling that you're invincible, something that, we encounter with cancer patients sometimes, where patients just can't believe that they're sick or can't believe their prognosis. That spirit that, we can't be defeated by something that's invisible or this could actually happen. It's sort of out of a movie.
Yeah, I think there's more than rather than a feeling of invincibility, it's more denial. I think particularly in countries like Australia, until recently, it had touched very few people personally. If you lived in a city like New York or London, you would probably know someone who died or at least had been severely ill in hospital. Whereas here, it's been more remote for people. It's not a reality for most people, so it's easy to go into denial and just go about your life as if everything's normal, which is exactly what you see in places like Sydney at the moment. Nobody's social distancing, hardly anyone's wearing a mask, everyone's just carrying on as normal. That's the big Achilles heel, which will probably result in a resurgence at least in New South Wales, if not other parts of Australia.
So, Raina, you've been advocating from the start universal wearing of masks, closing of all schools. Is there anything you were incorrect about, and why didn't they listen to you?
Well, that's several questions there. I'll start with the universal mask use. So essentially, all we've got available to try and control the spread is non-pharmaceutical interventions, keeping your distance, face masks, washing your hands, and getting tested if there's an indication for testing. And I say that rather than if you've got symptoms, because asymptomatic infection is quite a substantial part of the problem. And until we recognize that and manage the situation accordingly and test people who are asymptomatic but at high risk, such as being close contacts, etc., of a known case, then we'll continue to miss infections, which will then go on to transmit. So if everyone wears a face mask, then you really reduce the risk of transmission, because it both protects well people and also prevents people who may be asymptomatically infected or mildly infected and not realize they've got it from outward transmission as well. And there was a great example in the US of a hairdressing salon where two of the stylists had the infection, didn't realize they had it, but they kept working. They wore masks, and the policy in the salon was everyone had to wear a mask. So all the clients wore a mask and the hairdressers wore a mask. It was a mixture of surgical and cloth masks. They served 139 clients while infected. Nobody got infected. And yet one of the stylists at home infected her household contacts because nobody wore a mask in the house.
So it's pretty predictable. The other issue we've come across is this idea that it's either the economy or health, and we can trade one off. But that's a false argument, isn't it?
Yeah, it is a false argument, and I think Sweden is an example of it being a false argument. So they had no economic gains, and all they had was a lot of pain, a lot of death, a lot of preventable hospitalizations and illness for no economic gain. The pandemic has been economically devastating globally. It may take a very long time to recover, and it's going to be, if it not isn't already, like the Great Depression. So you can't just wish that away and think that if you ignore it and just carry on as normal, it'll just magically fix itself, because it won't. If you've got high numbers of people getting ill, that impacts your workforce and the ability to keep things going in the economy. So it is a false argument, for disease control. Disease control is necessary for economic recovery.
So let's move on to cancer patients. Very early on, Raina, you helped us with our guidelines. In fact, you're the senior author on our guidelines paper. We looked at rationalising patients on a case-by-case basis, but trying to defer unnecessary treatments, certainly defer routine appointments, switch to telehealth, reduce the number of agents being used if the patients were stable, offer breaks when we could. At the time we developed these guidelines back in February, March, we were very hopeful that they would be needed for a relatively short period. And it is possible to give cancer patients a break from treatment for, a period of a number of months in many circumstances, or to de-intensify their treatment. But now that this is going on, and I'd like to ask you how long you think this severe acute stage will last, particularly in Victoria, we're going to be faced with having to undo some of those initial suggestions of de-intensification of treatment. What's your advice? What sort of time frame do we need to be thinking about?
I think when we look at other cities that have had bad epidemics, and it's generally the same narrative that there was lots of social mixing and kind of resumption of activities, diseases started to rise, overwhelmed the health system, it peaked, and then of course, there was decreased mobility, increased social distancing, lockdowns, mask wearing, other measures, and then disease numbers started to come down. And so in New York, for example, they had their first case in March, and the epidemic peaked on April the 6th, but it was still pretty bad going till the end of April. So that was a period of about 2 months. So I think, and in Victoria, I guess beginning of July, end of June is when it started to really get serious. Maybe by the end of August, things will start to get better, but that depends on all those measures staying in place, social distancing, the lockdowns, the mask use, etc. And the nature of the beast is that as soon as you start releasing those restrictions, the disease incidence will rise if there's still infection in the community.
So it's lockdown until there's no community transmission as the most successful strategy?
I don't know if it's achievable to have no community transmission now because it's so widespread.
Is that just for Victoria, or you're talking the whole of Australia?
For Victoria, maybe for New South Wales as well, where the transmission may be more extensive than we are aware at this stage. I think that New South Wales is where Victoria was in the middle of June, and we just have to wait and see whether it remains just a few dozen cases a day, new cases a day. The other states, the biggest issue, the reason why New South Wales and Victoria have been the most vulnerable is the huge number of international travellers that come into those two states. The numbers of people coming in from internationally to other states is far, far less. And the same with New Zealand, far less than Australia. So it was always going to be New South Wales and Victoria that were at risk because of the fact the borders aren't completely closed. So those people coming from the raging pandemic outside were always going to bring the infection in. I think, I just think we're going to be playing a sort of stop, start game till we can vaccinate people, which is, having periods of normality and periods of restrictions, which alternate with disease incidence being high and low.
And let's talk about vaccination. You've always been very hopeful that there will be a vaccine just because of the huge research effort and money going into it. Do you think that there will be any restriction on any type of vaccine in terms of more vulnerable people, immune suppressed people?
It depends on the type of vaccine. There's only one vaccine being developed that's a live virus vaccine, as in the actual, attenuated SARS-CoV-2 virus vaccine. There are several vaccines that are vectored vaccines, so they're vectored on adenoviruses or other viruses. So generally, unless it's a live virus vaccine, you can give vaccines safely to immunosuppress people. There are quite a number of the new vaccines being developed are subunit vaccines or antigen-based vaccines, which should be fine to give immunosuppressed people. The question is, how immunogenic will they be? But yeah, in terms of safety, unless they're live viral vaccines, it should be fine.
What do you think the time frame is? Or is that just asking you the piece of string question?
Yeah, I think so. It's hard to say. A lot of people are saying it might be in the first quarter of next year, but then there's going to be a question of supply as well. It's highly likely that there won't be adequate supply at the beginning. And it's also highly likely that countries like the US will buy up everything and everybody else will have to stand in line waiting. So the likely scenario is we'll have a limited number of doses initially and have to prioritize who gets them. And I think it'll be the healthcare workers, hopefully, not the politicians who are the highest priority for vaccination. It'll also depend partially on whether there can be vaccine production in Australia. So any country that has vaccine production capacity, and Australia fortunately does with CSL, but that again depends on them getting a license from whichever company makes the vaccines to get some kind of agreement to manufacture it here, and that's another complicated scenario.
So let's talk about healthcare workers. In terms of risk from patients, is there any difference between the type of patient and the sort of load that they carry in terms of risk to healthcare workers?
Well, I think, generally someone who's immunosuppressed or older probably will have a higher viral load. We know that from other infections, things like influenza, and that the elderly particularly, they have a higher viral load and they shed virus for longer. There's a phenomenon called immunosenescence, which is the progressive decline of the cell-mediated immune system from the age of 50 onwards, which really impacts the ability of older people to respond strongly to vaccines and to infection. So age and immunosuppression should be indicators of high viral load. But there's also this super spreading phenomenon that's been observed. So some people say that 20% of people are responsible for 80% of the transmissions. And in those people, it's probably a combination of both host factors as well as environmental factors. So the super spreaders may be people who are in super spreading environments like a cruise ship or a nightclub or some crowded place where they're having contact with a lot of people. But they may also be innate host factors that make them shed virus much, much more than other people and be much more infectious. So, and that is unpredictable. We don't have ways of predicting who is a super spreader, but we do know what settings are super spreading settings. And hospitals, unfortunately, are one of those settings.
With our cancer patients, both they and us have to weigh up the risks of them coming to the hospital to be seen and to have treatment versus delay. You've given us some really good information that this is going to take a very long time before we go back to any sort of normality. So as oncologists, we'll need to have a strategy that goes over many, many months for how we're going to manage our patients. What do you think about strategies like home delivery of chemotherapy? Sounds very good, but what if the nurse is infected?
So, obviously, if you're doing home delivery of chemo, then the nurse would have to be wearing PPE and a mask, and, they'd have to be, maybe do it in the back garden, if that's possible, or on the deck, somewhere where there's fresh air, or open the windows, make sure there's adequate ventilation. But it's certainly better to be exposed to one person than be in a hospital setting where you're exposed to lots of people. I think you can also look at elective surgery and what they're doing there before they come in for elective surgery. They're testing everyone to make sure that the patients are not infected, but you'd also maybe want to test your staff in that unit.
So we are aware of units, especially in Europe, where they have routine testing. I think I was speaking to someone from the Royal Marsden last week. He's saying they're having swabs every week. As far as testing chemo patients, it's a matter of when and how often. Chemo isn't usually a once off, but all elective surgery patients are being tested in Victoria. Ironically, for urgent surgery, patients are being tested but not waiting for the results because of the delay in testing.
Yep.
So they're being treated as potentially COVID. Why can't we get a more rapid test rolled out in a more widespread way?
So there are lots of rapid tests in development, and I think it's only a matter of time before those will be widely available for the clinical setting for exactly those kind of purposes.
Have you got a sort of time frame, weeks, months?
I don't know, sorry, but it could be months. We could be seeing those kind of rapid tests available this year.
Okay, sorry to pin you down with all these difficult questions. I'm trying to imagine the questions that our audience has as clinicians. Talk to us about healthcare workers. We know a lot of healthcare workers appear to have been infected in Victoria, even to the point where people were saying that they didn't get their infection at work, they got it out of work. Seems odd to wear lots of PPE at work and then do activities outside work that expose you.
Which people were saying that, Eva? Was it the healthcare workers who got infected saying I got it outside, or was it hospital management?
It was healthcare workers, but you wonder who had what information they had been given.
Yeah.
I think in Victoria, people are coming around to realising that most healthcare workers who are infected are being infected at work, although there are statements to the contrary.
So I think you have to look at vested interests and conflicts of interest here in attributing where people got infected. I know in New South Wales, they're attributing just under half of the health worker infections to the workplace. In Victoria, it was something like 17 to 20% only being attributed to the workplace. So in terms of attributing in the source of infection when it's a healthcare worker, I think it has to be done by an independent adjudicator who is not part of the hospital administration and is not part of the health department, because it really has to be adjudicated fairly and transparently. And that involves taking a detailed contact history both in the community and at work. And really, if there's no known contact in the community, you can't just say, oh, the ward clerk on the COVID ward got it, in the community. And I understand that kind of attribution is happening. And I think there's a kind of confirmation bias that's happening there as well. So if there's a belief by, say, management that you can only possibly be exposed if you're within 2 meters of a confirmed COVID patient, then they could be looking at every health worker who gets infected and saying, okay, you're the ward clerk on the COVID ward, you didn't go within 2 meters of a patient, and therefore you got it in the community. And the ward clerk, of course, trusts all these important doctors in white coats telling her that. And so I think there's been a lot of that going on. And I did a little experiment to test my theory where I looked at the numbers. Say there's when I did the experiment, there were 1,000 healthcare worker infections in Victoria. I looked up on APRA the number of registered healthcare workers in Victoria. There's about 194,000. And I worked out a rate of infection for the health workers versus the general community. And then I worked out an odds ratio overall. So Victorian healthcare workers were 3.5 times more likely to have COVID-19 than the general community. And then I broke the 1,000 healthcare workers up into the 200 that they said, yes, they did get it at work, and the 800 where they said they definitely didn't get it at work. And I worked out an odds ratio for those. And guess what? The 200 that got it at work had a significantly lower risk of infection than the general community. And the 800 who they said didn't get it at work were 2.5 times more likely than the general community to be infected. So how is it that health workers who got it in the community have almost, a 2.5 times greater risk than the rest of the community? It's just a complete nonsense. That tells me there is confirmation bias going on and false attribution of source of infection. And it's really an important issue because it's not just about health workers dying and getting infected and getting ill and facing the long-term sequelae of this infection, but it's also about the furloughing of huge numbers of healthcare workers who need to be quarantined. In Tasmania, where about 84 health workers got infected in the Northwest Regional Hospital outbreak, over 1,200 health workers had to be quarantined and the hospital had to be shut down. So you can actually cripple the health system. If you're just letting healthcare workers get infected, you can cripple the health system. I mean, the other thing is there's been numerous studies now that have tested the environment in the hospital ward where there's COVID patients, and it is highly contaminated. You can find virus everywhere on all the surfaces. You can even find it in the air. And studies have shown that the viable virus can be found 16 hours after aerosolization. So you can have a patient in emergency, the patient's been transferred to the ward, and somebody else walking through emergency after the patient's gone could conceivably get infected. So health workers are working in a highly contaminated environment where there's a much more intense exposure to virus. It's a dangerous environment. It's a matter of occupational health and safety that health workers, need adequate protection.
And what is adequate protection, Raina?
So they need airborne precautions. If you're treating a COVID patient, you need to be using airborne precautions. And in Victoria, it's just sad that only after over 1,000 health workers got infected did they change the guidelines from the national guideline. Victoria broke with the rest of the country, which was just using the national guidelines as an excuse to not provide adequate protection to health workers. So fortunately now in Victoria, health workers treating COVID must be provided a respirator and the other precautions. But in the rest of Australia, hospitals and health systems can just refer to the national guidelines and say, no, a surgical mask is all you need.
One of the other issues we're having in Victoria is the length of time that contact tracing is taking. By the time patients are being identified, it's been about 14 days already since their contact.
The human resources requirement for contact tracing is 10 to 20 times greater than for managing cases. For every case, there might be 25 contacts. So the day that there were 700 plus cases in Victoria, on that day alone, they might have had 7,000 contacts to trace, or even as much as 17,000 contacts. So, and that was just for that day. So it's a huge requirement. And, unfortunately in Australia, not enough people have downloaded the COVID Safe app. So the health departments have to do manual contact tracing. They're sitting there with whiteboards and, ringing up people and trying to follow them up. And, the Victorian Department of Human Services, from what I understand, is the most underfunded in the country for the public health contact tracing type things. So they're working, from a huge disadvantage.
Has the app been of any benefit?
No, because not enough people have uploaded it. So the way it works is, say you're in a pub and there's someone there with COVID and there's, 50 people in the room. Say that only 10 people have the app in the room and the person who has COVID doesn't have the app. So nobody's going to actually get notified that they were in contact with this person. It's just a probability game. You need enough people using the app so that wherever you are, there's a high probability that most people around you will be using the app and that you are using the app. That's how it works.
Why aren't people using the app? Was it the initial problems with the app?
Well, I think people have been concerned about privacy issues, but I also think the messaging around it hasn't been very good. And I don't think there's a good understanding that the reason it's not working is because not enough people have uploaded it. I think there's a misperception that it's just not working because there's something wrong with it.
Oh, that's very helpful because I actually have that misperception. So, Raina, just taking you to this issue of furloughing, I'm aware of one example where we were doing some contact tracing, and because the exposure was around 12 days prior to the date that we were notifying people, those people only had another 2 days to quarantine. Does that make any sense? Or is it that contact tracing is only valid if you get them very soon after the exposure? Because we had to tell patients suddenly to go and isolate for another 1 day when they'd been walking around for the previous 13.
I think in that circumstance, the thing to do is to test that person. If they've been walking around for, 10 days and they've got 2 days left for the quarantine period, you have to test them. Every asymptomatic contact should be tested. If you're a close contact, you're at high risk. If you don't test the asymptomatic contacts and just say, go back to work, because in that 10 days, they may have developed infection just the day before or, 2 days before. So they could be going back to work infectious. You should be testing every asymptomatic contact in that circumstance. I mean, my view is every high-risk asymptomatic person in an outbreak setting or contacts should be tested.
But shouldn't we also be doing the tracing so that it only takes a minimum time since?
Absolutely, but the human resources requirement has been exceeded. The department is not able to, clearly is struggling to cope with those demands. I mean, imagine, you might be having to trace 15,000 contacts a day, day after day after day, including on weekends. It's not, no matter how wealthy and well-resourced a health department is, nobody can manage that. You really need to look at digital contact tracing. That's the only way to keep things under control when an epidemic gets really big. They did it in South Korea and in China.
So they did give up on it in the UK and in the US, etc. Is it time for Victoria to
In the US, they gave up on everything, It was just like, they gave up on testing, they gave up on everything, In the UK, there was some misguided views in their committee, SAGE. It's in their minutes, when they said back in February, if the epidemic gets too big, we'll just stop contact tracing. But contact tracing actually is one of the most influential things in determining epidemic size, because the contacts are the people who are at the highest risk of becoming infected, who will then go on to infect other people and make the epidemic grow. So if you don't stop them from infecting others, the epidemic's going to blow out catastrophically. It's really important to trace the contacts and quarantine them.
Is that what's happening in New South Wales, and is that why the numbers are staying low?
Well, I mean, the numbers are low so that that human resource stress is not there, right? if they're only having 15 new cases a day, they can track the contacts. But even that is quite a big job because it's every day, So 15 new cases could be 150 or 300 contacts to trace in one day. That's still a lot. It's not 7,000 contacts to trace, but it's still a lot.
So, Ryan, I bring you back to a question earlier on about your views about what we needed to do up front to stop this pandemic getting out of hand in Australia. I don't know if you advised Jacinta, but she listened to someone smart like you. Is there anything that you advised that you think was not correct?
No, I don't think so. I did feel that school closure is should be part of the response, and that's because children mix in large numbers in very high intensity in schools. It appears that it's the lower risk of symptomatic infection is in children under the age of 10. But in children over the age of 10, it seems like they transmit and get infected as much as adults do. So high school is a massive risk, and we've seen how many school closures have we had in Australia throughout this pandemic. I've lost count of the number of schools that had to be closed because a student or a teacher or students were infected. And we've had an outbreak already in at least one school, I think, in Victoria recently. So in one sense, it's if you're trying to achieve elimination or to suppress the virus right down, you can't do it keeping schools open. You just can't. So people refer to some of the serological surveys where they tested the serum of population cross sections and found very low seroconversion in children under 10. There's also a lot of research to suggest that seroconversion is actually related to that you've actually got to have a good going infection to seroconvert. That if you have a really mild infection, you may not seroconvert. So it could be, that children just get very mild or asymptomatic infection and don't seroconvert. That could explain the lack of seropositivity in the under 10s. So there still could be transmission happening in that younger age group.
So, Raina, for the oncologists going to their clinic tomorrow, what do you recommend to keep them safe and their patients safe?
So wear your PPE, keep your distance. It's obviously hard when you've got to do a physical examination, but, if you're wearing your respirator, gloves, etc. And I think the patient should be masked as well and follow those precautions. And when you can do telehealth, do telehealth.
Well, Raina, it's been a real privilege to have someone with your understanding and also your passion and compassion, willing to speak out if you think that some of the politicians or even some other experts have not got it right. We haven't done very well. I'm recording this from lockdown in Victoria. There's a very bad sentiment around, and we really do need to have the science predominate. As a final question, particularly with masks, can I ask you, why is it that there is so much division, particularly we've got expert committees, why is there so much division on something where the evidence seems so consistent?
So there's a long history of kind of anti-mask culture in certain quarters, and it's not specific to this pandemic. It goes back a long way. It goes back even to the SARS epidemic in 2003. And I think the what we've seen play out is not about science or evidence. It's just about ideology and dogma. I just would encourage people to go back and look at the SARS Commission report from what happened in Toronto in 2003, where they argued that SARS was only spread by droplet and contact. You only needed a surgical mask. And of course, they had a huge outbreak and several healthcare workers died, and there was an investigation afterwards. And they just failed to use a precautionary principle. It's a pandemic. Anyone who says they know everything about the virus and how it's transmitted is either really arrogant or a fool. There's a lot we don't know. We're learning new things every day. So really the case for using the precautionary principle, which is you don't wait for scientific certainty, you give health workers the optimal protection to ensure that nobody gets infected or dies. And that hasn't been done. That hasn't happened, So I think it's just really sad that the price is paid by healthcare workers, some of who are in intensive care right now and very ill. And I just hope we don't keep making the same mistakes.
It's really sobering. It's a bit shocking, but it's been a very enlightening and important interview. And I thank you very much for your time.
It's a pleasure, Eva, and all the best to all your listeners.
Hans, who was here in Australia with me when COVID ravaged Belgium, managed to escape and go back to Belgium just before we really started getting hammered here in Victoria. Over to you, Hans. You went back into lockdown this week. Tell us what's happening in Belgium, and then if you can present your data, please.
Thanks, Eva. So as you know, we had our peak at the time when I was in Australia, and then it went down, but also the measures were changed. So we could see more and more people. And from the last, let's say, 2, 3 weeks, we see again an increase, quite heavy increase in number of cases. So we're in some kind of second lockdown now, where we can only see 5 fixed people for the coming 4 weeks and try to flatten the curve. So, concerning the articles that I looked in the literature about COVID, I was interested in finding what is now the number of people that work in the hospital staff that gets positive with COVID. And there was a very good article published. It's a Belgian article, and it's published in JAMA in July 2020, and it measures the hospital-wide COVID antibody screening in 3,056 staff in a large center in Belgium. So, as already said, Belgium has a very high burden of COVID-19, and that's why in these large centers they saw quite some patients with COVID. The first case we had was around March, with a peak around mid of April with 150 cases admitted. And what these authors did is they tested from April 22 to April 30 all persons who worked in the hospital. So also clinical, non-clinical, volunteers. And this is important, they tested by serological testing. So it was for the antibodies, not by PCR. The staff who had active symptoms, they were quarantined and they were not tested. And so they really want to know how many people had antibodies for COVID-19 within the hospital. And the staff was also asked to complete a survey on the exposure risk and symptoms. So what were the results? From more than 4,000 staff invited, around 3,000 participated, so quite some number. And overall, 197 staff members had antibodies. So this was around 6.4%. And they also looked at relations with different factors, and actually being involved in clinical care or with patients with COVID-19 or exposure with COVID-19 positive coworkers was not statistically significant associated with antibodies. In contrast, having a household contact with suspected or confirmed COVID, this was associated with antibody positivity. So what the main message they had is that the chance of getting it within the hospital is quite low, that the chance to get it at home or out in a bar or wherever you go is much higher. And of those with antibodies, 15%, so 1/5, so 15% reported no symptoms. And anosmia, as well as fever, cough, were associated with antibodies, which is not a surprise. So I think this is a very interesting publication. That's why I also looked at two other publications, one in Italy and one in Spain, what the numbers were there. And the second article I want to discuss is one in Italy, in Verona, also with a high burden of COVID. And this was also a paper published mid-July. They tested around 6,000 health workers, and they did it with PCR, so no antibodies. And there they state they have a cumulative incidence of 4%. The third article was actually an article where they published results of a hospital in Madrid, Spain, and they also looked at COVID infection amongst healthcare workers. This is a paper accepted mid-July to appear in the Journal of Hospital Infection. It's a retrospective cohort study to measure the cumulative COVID-19 incidence, And what they did is that all healthcare workers were included between February 24 and April 30, so around the peak, but only tested the ones with symptoms, so not the ones with no symptoms. And they only tested with PCR, so no antibodies. And they found that 11% had confirmed COVID-19, and they also detected a few clusters in specific departments, suggesting that a proportion of transmission occurred from one healthcare worker to another healthcare worker. But in conclusion, I think I can say, when looking at these three articles, that the chance of getting infected within a hospital is quite low if you use very good protection. So maybe you don't know, but in Belgium, we didn't have any problem with protective measures, also with material. So all healthcare workers were very well protected. And as already stated, most patients or most healthcare workers got infected while at home and not within the hospitals. So I think that's very important message also in the future, that try to focus on well use of masks wherever you can, especially in the hospitals.
Thanks, Hans. Can you clarify what sort of masks you're using? Are you talking just the surgical masks or N95s?
So actually, we use in the hospital surgical masks. So that's what everybody is wearing. So it's obligatory for healthcare workers to wear surgical masks. Only on the departments where they treat patients with COVID-19, there they have specific equipment, so extra measures. But in the rest of the hospital, we use surgical masks, and visitors, they can use even homemade masks. So.
Yeah, so I think that issue about the mask is important. Again, as we go to air, there's a big debate about the rotations of the trainees and whether that should still have gone ahead, and they're doing a test 5 to 7 days before their rotation. But as you say, if everyone's wearing masks in the workplace, that should minimise the transmission. And first symptom, stay at home, get tested.
Yeah.
That probably has a lower impact on the workforce than quarantining people for 14 days.
Yeah, that's true.
So, Craig, we'll now move to your papers, thank you very much, that specifically address the data to date about the risk of COVID-19 for cancer patients.
Thanks, Eva. And of course, everybody can click on the link if they want any more information in the papers. But I'm just going to give a quick overview. The first one is about a report from Guy's Hospital in London, which is a large cancer centre. In the recent podcast, we talked about data out of the Memorial Sloan Kettering in New York. And this data out of Guy's Hospital, a large single institution experience, is very similar. So there's some consistency in the literature about the outcomes. And that's really showing that the mortality rate of people with the diagnosis of cancer is around the 20% mark. So that's, substantially higher than what we'd expect in the general population. And in the independent multivariate analysis, the things that came out as predictors of death were being of Asian ethnicity, receiving palliative treatment, or having an initial cancer diagnosis more than 20 months before the onset of COVID, dyspnea at presentation, or a high CRP level were all positively associated with COVID death. So again, interesting data and pretty consistent with previous publications. The Asian ethnicity was a little bit unexpected. I'm not a recent resident of the UK, but did train at Guy's Hospital some years ago. I wonder whether the Asian ethnicity is associated with lower socioeconomic class or housing conditions, perhaps. The next two papers together are from Lancet Oncology, and they're looking at some modelling of what the impact would be on delays in diagnosis in the UK, and in the future what that might mean for cancer outcomes. So these were two quite depressing papers. Really, they have made a bit of a splash when they came out, because there's some similar data emerging in the state of Victoria and Australia, where we know that the cancer diagnosis rate is substantially lower so far in 2020. Some cancers being down as much as 70%, breast cancer down by 37%. And the diagnosis rate in the month of July has, in inverted commas, fallen off a cliff, in inverted commas, in the state of Victoria. So that will have an impact, and some modelling suggesting quite provocative impacts on cancer outcomes that probably will exceed the impact of COVID, reflecting our need to balance business as usual with COVID. But both of these papers from the Lancet Oncology, again, for the sake of time, will allow people to click on the link for some more information. But one looked at delays to diagnosis. They have a system in the NHS with certain symptoms, patients with certain symptoms, that GPs fax a referral to the hospital, and those patients have to be seen within 2 weeks. So during the first part of lockdown, there was substantial delays, and they did some modelling around, depending on the length of the delay and the duration of the lockdown, what would that actually mean in UK in lives lost or life years lost. And so these figures are from the UK context, but again, it's essentially, with a small delay, you can look at perhaps a 10% worsening in the cancer outcomes. So when you put that across prevalent disease, that has quite substantial impacts at a population level. And then the second paper looked also at some modelling with some quite provocative data as well about the impact of those delays. So it's a watch this space in Australia, and a reminder that, yes, we need to look after people during the COVID pandemic, but yes, people still need to be screened. People still need to be seen by telehealth or come into the centre if need be for ongoing treatment and for workup of new diagnoses.
We do try and tell him that you don't need to say click on the link all the time, but he likes to say it, and sometimes in French as well. And now for the short bites for the COVID edition. The first paper was in JCO Oncology Practice, entitled Assessing the Impact of the COVID-19 Outbreak on the Attitudes and Practice of Italian Oncologists Towards Breast Cancer Care and Related Research Activities. This was a survey that had 165 oncologists who responded, mostly who worked in breast cancer units, and it documents their change in practice during the time of the major emergency in Italy. Not surprisingly, in the neoadjuvant setting or adjuvant setting, less weekly paclitaxel was given, less dose-dense schedules, less upfront paclitaxel for HER2-positive disease with the weekly schedule, less use of CD4K inhibitors for luminal tumours where there was less aggressive characteristics. There was also a significant change with delaying time of monitoring tests and with assessing treatment response, and also flushing CVADs, central venous access devices, and clinical research and scientific activities were reduced in 80%. The second paper by David Waterhouse, published May 26, 2020, The Early Impact of COVID-19 on the Conduct of Oncology Clinical Trials and Long-Term Opportunities for Transformation, Findings from an ASCO Survey. So this survey was sent out in March by ASCO, and it'll be very interesting to see serial results. I'm sure these surveys will be repeated. It went out to their Cancer Research Committee and also their Research Community Forum steering groups. So 32 different respondents, 14 from academic programs, and they talk about a switch to remote patient care for trials, remote visiting, remote monitoring, and they talk about the fact that this was seen by patients and staff as a positive shift, but there were numerous challenges, including enrolment, protocol adherence, decreased patient visits, staffing constraints, and limited availability of ancillary services for trials. They do point out long-term lessons and changes for good, which leads me to my third paper that comes from Queen's University in Ontario, Canada, the large group there, called COVID-19 Pandemic, an opportunity to reduce and eliminate low-value practices in oncology. This is a viewpoint from Bishal Gayawali, and he talks about the new methods of healthcare delivery, home-based care, telehealth, The fact that value-based cancer care has been garnering attention, mainly due to cost of cancer care in recent years. The well-known debate about what endpoints to use to value cancer treatments. And if you haven't heard, check out the Oncology podcast where we talk about the ESMO magnitude of clinical benefit scale and the ASCO value framework. But he actually makes the point that in the pandemic, we are all working in a resource-limited setting. So we're doing what he says low and middle income countries do every day when they make choices about care. And it's interesting to see the difference in guidelines in the pandemic. So Cancer Care Ontario divided treatments into priority levels A to C, where A was to continue the standard treatment, C was to delay until the pandemic's over, and B was to make individualised decisions. In the UK, the NHS prioritised 6 levels based on treatment success rate, where curative therapy with a more than 50% chance of success receives a priority 1 level. Priority 6 is for non-curative therapy with an intermediate defined as 15 to 50% chance of palliation or temporary tumour control and less than 1 year of life extension. And I dare say we should reflect how many of our treatments may in fact be priority 7 or 8 with lower benefit than that. Now, the ASCO guidelines, not surprisingly, perhaps suggest just a case-by-case approach and give no further documentation. Of course, there are some guidelines written by our own Australian group, targeted to our Australian setting, published in JCO Oncology Practice, and click on the link, Craig, to access those. But this viewpoint does notice that there is less, in inverted commas, indiscriminate off-label use of targeted therapies based on genomic alterations. It says that if we revert to practice as usual post-pandemic, with the amount of testing, imaging and treatments, we will have lost the opportunity that this pandemic offers in really reassessing the value of our treatment. And his final sentence, after my own heart, says, truly, no matter where we work, we are all global oncologists, because at the time of the pandemic, we're all resource limited. Spare a thought for those in low and middle income countries. And we will be doing an upcoming podcast looking at low and middle income countries with some guest interviews to understand how our colleagues around the world are managing with their various challenges, both COVID and non-COVID. So that brings us to the end of this sobering C-word episode. It's now time to say goodbye, keep safe, wear your mask, and let's hope that the situation in Australia, Belgium, and all over the world takes a turn for the better. Thanks to my co-host, Craig.
Thank you, Eva. Thanks, Hans, and thank you, Rachel.
Hans.
Thank you all.
And thanks, Rach, to our wonderful producers. Stay well. Bye for now.
You've been listening to the Oncology Podcast. If you enjoyed today's edition and would like to subscribe, head over to our website, oncologynews.com.au, and sign up to our newsletter. Thanks for listening.